Hi, Oliver. Ollie, even. Can you hear me okay?
I can hear you. Can you hear me?
Yes.
Right,
When I see people's name in print, I automatically
That's all right.
call people by their proper name, so apology. So I think that we will give a few minutes before we start this workshop to give people a chance to nip for a comfort break. Hi everyone. We'll just give it another couple of minutes before we start, just to allow time for anybody to come in who's gone for a comfort break, and then we'll start the session. I hope that's okay. I think we're expecting a few more people. So just take a minute for reflections from this morning's session, and we'll get cracking really shortly. Welcome, Oliver and Cath.
Hello.
Okay, I think this will probably be a good point to make a start if everyone's okay with that, because we do need to try and finish the session by 12:25 if we're going to be kept on track. And we've got some really great speakers with us this morning, so we want to make sure we give you opportunity to share your presentations. So my name's Rachel Garton. I'm an Experience of Care Senior Manager, and I work with NHS England's Experience and Partnerships team. The dominant part of my role is related to the unpaid carers policy agenda. The presentations today are by Ollie McQueen, who also works for NHS England, and Cath Pickles from Restitute, and they'll introduce themselves shortly when we move on to those. And we're also supported today by Ollie Benson, who works in the NHS England Experience and Partnerships team. Could we go to the next slide, please, Ollie? Thank you. So, yeah, the first thing to say is thank you so much for choosing to join the workshop. So the session will be recorded, so do turn off your camera if you'd prefer not to be recorded today. And if you can keep your microphones mute during the presentation, then that would be great. So feel free to post any questions or comments in the chat box throughout the event, so we can refer to them in the Q&A at the end. If we run out of time for your questions to be answered, we will look at questions and try and get back to people if they would like us to post-event. So, you know, we will keep an eye on that and make a note of those key questions. And you will also be provided with our team's contact details throughout the day. So if you do need to contact us for any reason, you can do, and we will, as per the chair's pledge this morning, we will get back to you. You can enable closed captions for subtitles during the meeting, and the recordings of the workshops will be on the NHS Future site. So if you're not on the NHS Future site for unpaid carers at the moment, we will give you the details to be able to join up to that site. The presentation does contain some sensitive content, so I do believe there is a slide, Ollie, with the details of help that's available. And also, obviously, you can step out if the content is a struggle for you. We want to create an open and safe environment today, but sometimes, you know, the reality of people's situations can be quite triggering for others. So just a shout out for that, and there is help available if you needed it. Next slide, please. So I hope you're in the right workshop. This is the Health Inequalities workshop. We've got fantastic presentations lined up from Oliver and from Cath. And I think for me, the key thing to kind of start us off is that, you know, we want the best support that we can give for unpaid carers, and we want to make sure that unpaid carers, the challenges that they faced, are reduced. I think what we can't do is assume that the support that people need is a one-size-fits-all, and we can't assume that all the challenges that unpaid carers face are the same. So we're really fortunate today to have Oliver, who's going to talk to us about LGBT plus unpaid carers from NHS England. So I'll pass over to you, Oliver, if you're ready.
Yes, absolutely. Good morning. Thank you very much. My name is Oliver McQueen, and I am Senior Project Manager and Equality Manager working in the National LGBT Health Team together with Dr. Michael Brady. And today I'm going to be talking about the LGBT plus unpaid carers, and it's me realizing today actually that I was a carer several times, and at that time back then, I didn't even realize that I was a carer. At that time, we didn't call that, carer. It was in my mind somebody who is paid by the state, by local council, not the person who provides help to friends and family. So if we could go to the next slide, and I have to apologize to start with because I got lots of facts and figures. But I thought that we need some background to start with. So according to the census data from 2021, more than 1.3 million people, which is 3.3% in England and Wales, identified as lesbian, gay, or bisexual. A higher proportion of LGBT people live in urban settings. In Wales, this is Cardiff, was the local authority with the biggest LGBT plus population, which was 5.3%. And in England, it was Brighton. It is Brighton and Hove, and the local authority with the highest percentage, which is 10.7% of people identifying as LGBT plus, followed by London, which is 4.3%. And a study by Carers UK found that 1 in 10 people who identified in general as LGBTQ+ are also carers for up to 19 hours per week. The age group most likely to have identified as lesbian, gay, bisexual, or another minority sexual orientation were those aged 16 to 24 years, which is almost 7%, and the majority of LGBT plus people were aged between 16 and 34 years old, almost 58%. And the recent data shows that on one hand, 8.8% of people who identified as LGBT+ were disabled, compared with 20.1% of the overall population, which may reflect the young age profile of those identifying as LGBT. But on the other hand, 16 to 24 years old who identify as LGBT+ were much more likely to be disabled than the overall population of England and Wales are of the same age. And according to the latest census as well from 2021, more unpaid carers aged 16 and over are lesbian, gay, bisexual, or other than non-carers. So 4% of unpaid carers identified as LGBT, compared with 3% of non-carers in the overall population. There are 147,000 LGBT+ carers in England and Wales. Most of them, the higher percentage is female, 86,000, and male, 61,000. England has 138,000 LGBT+ carers and Wales has 9,000. And the highest proportion of LGBT people care for 9 hours or less every week. So more unpaid carers are disabled than non-carers, and despite the an overall reduction in proportion of people with disability between the census from 2011 and 2021, the percentage of unpaid carers with a disability have increased to 28% in England and 30% in Wales. So over a third of unpaid carers and over a third of unpaid carers providing over 50 hours of care per week are disabled in both England and Wales. The ethnicity results are similar to those in 2011 census and showing that majority of unpaid carers are white, are English, Welsh, Scottish, Northern Irish, or British, equal to 70% in England and 93% in Wales. In terms of religion, the carers most commonly identified with Christian, with 49% and 46% reporting this as the religion is in England and Wales, respectively. And there has been an increase in the percentage of unpaid carers identifying with no religion in both England and Wales, which is reflecting changes in the wider population. And just over half, 51% unpaid carers aged over 16 are married or in a registered civil partnership in both England and Wales, which is higher than non-carers. However, since the previous census in 2011, there has been an increase in the percentage of unpaid carers who have never been married or registered in a civil partnership. If we go to the next slide. Did we change the slide?
Yeah, slides on slide 7.
Okay, brilliant. Thank you so much. So on this slide, you can see that 262,000, which is 0.5% of the population age 16 and over, said that their gender was different from their sex registered at birth. In England, the region with the highest percentage of people who said that their gender identity was different from their sex at birth was London, 0.9%. In Wales, more than 10,000 people, 0.4%, indicated that their gender identity was different to their sex register at birth. So London has the highest proportion of people identifying as transgender men, 0.16%, and the same percentage is for trans women. And within England, the region with the highest percentage who reported that their gender identity was different from their sex at birth was London, was 0.91%, and the lowest number was Southwest. What was interesting to me is the fact that the city I lived for many years, Norwich, has second highest proportion of trans and non-binary people outside London, is 3,572 Norfolk residents said that their gender differs from the sex they were assigned at birth. What is also interesting fact is while only 10% of people said that they did not speak English as their main language on the census, it appears they made up 29% of the total number of transgender people. For example, the London borough of Newham had the highest proportion of people who identified as transgender. It's 1.51%, and there are also has one of the highest rates of non-English speakers, is 35% compared to 9% nationally. And this suggests that a significant number of trans people either came from outside the UK or speak English as their second language, using their parents' language on a daily basis. In 25,355 unpaid carers said that their gender identity is different from the sex registered at birth. Of the carers who said their gender identity is different from their sex registered at birth, almost 11,000 are providing 19 or less hours a week of unpaid care. Almost 8,000 of them are providing 20 to 49 hours a week of unpaid care, and 6,500 are providing 50 or more hours a week of unpaid care. And many of the carers are not receiving, it's worth to mention that many of the carers are not receiving support from paid care workers, but some had joined local carers group, and however, some carers felt that support groups and activities were only mildly helpful, particularly during the pandemic when everything had shut down and people's social life dwindled to absolutely nothing. But there are also people, on the other hand, saying that during the pandemic, when events at their local care center moved online, it became easier for them to connect with others. One of the carers said that more hybrid sort of attendance should be generally more available for everyone, as this is a better form of engagement and support. According to Carers UK, the experiences of trans carers being in employment can improve well-being. However, trans people can face challenges in the workplace, and some trans people can experience discrimination in the workplace. A survey of employers found that 1 in 3 employers said they are less likely to hire a transgender person, and nearly half, 43%, were unsure if they would recruit a transgender worker. And trans people who also have caring responsibility may face additional barriers to being in employment due to demands of their caring role. And research suggests that 2 million carers have reduced their working hours, and 2.6 million have given up work to care in general, in the general population. And I probably don't have to even mention that unfortunately trans people are disproportionately affected by mental health difficulties. And 46% of trans people, including 50% of non-binary people, have even considered taking their own life. And carers in the UK estimate that there are 240,000 of LGBTQ plus carers in the UK. So in terms of the challenges, if we could go to the next slides, please. In terms of the challenges, people from LGBTQ plus communities face higher rates of homelessness, higher rates of domestic abuse and sexual violence, lower rates of physical activity, higher rates of smoking, and substantially higher instance of mental health issues and higher drug and alcohol dependency. There is a focus group run by career trusts for young LGBTQ plus carers, and they found that LGBTQ plus young adult carers are being negatively impacted in most areas of their lives because of their caring role, gender identity, or sexual orientation. And for instance, some figures again, 83% had experienced bullying in school, 88% reported to have or to have had mental health problems, and 80% rated their own health as just okay or poor. The 2011 Stonewall survey found that 3 in 5 older LGBT people were not confident that social care and support services like paid carers or housing services would be able to understand and meet their needs. And research by Garton and the LGBT Foundation found that 58% of LGBTQ plus carers say they would like to access mental health support, such as counseling, and over a fifth, 21% to be precise, of LGBTQ plus carers think that the services would not meet their needs as an LGBTQ plus person was a barrier. And some people from the LGBT plus community move away from the communities they have grown up excuse me, due to issue at home. And 93% of LGBT specialists and service users consider that more work needs to be done to improve end-of-life services for LGBT people. So what are the most biggest challenges? So one of them is social isolation. So majority of LGBTQ plus carers experience social isolation in their role and are much more likely to live in poverty. And some of the reasons are limited support networks, stigma, prejudice, and discrimination. And this is compounded for LGBTQ plus carers, especially those from older generation. And the Carers Trust found that 83% of young adult LGBT carers experience bullying at school, as I mentioned, mental health problems, and feel that they are treated differently because of their sexual identity. The next barriers and challenge is negative experience. Some LGBT plus carers reports encountering prejudice, bias, stigma, discrimination, or insensitivity from healthcare staff, leading to feelings of marginalization or unwelcome treatment. And this leads to hesitation to even seek support, and because of that, further worsen their health issues. Then another one is lack of recognition. Their caregiving roles may go unrecognized or undervalued, especially if their relationship is not acknowledged legally or socially. Also, NHS services may not fully recognize or validate the unique challenges faced by LGBT plus carers, leading to insufficient support or resources. Also, lack of family support, especially if your family do not know about or approve of who you love. Feelings of rejection and isolation can lead to depression, anxiety, low self-esteem, and even suicidal ideation. And this is even worse when the family plays a role in providing access to education, housing, and healthcare support. And stress from family rejection is associated with increased risk of substance abuse, risky behaviors, and poorer overall health. Another barriers is LGBT plus parents who are also carers face a range of unique challenges that can impact their well-being and their ability to access support. Facing societal, not only societal but also healthcare professionals' prejudice or discrimination can lead to feelings of isolation, making LGBT plus parents hesitant to seek support, potential rejection of or lack of understanding from extended family or community members, potential legal challenges around parental rights, especially in contexts where law are ambiguous or unfavorable. Also, assumption from family members. If you do not have what is considered a traditional family, other relatives might assume that with fewer commitments at home, the caring responsibilities should automatically be taken on by those without children. The assumption may lead to anxiety about coming out or being authentic, especially if the individual fears rejection or disappointment. If the individual's identity is discovered unexpectedly, it can cause feelings of betrayal or hurt, especially if family members react negatively. Also, legal and policy barriers. Example, legal recognition of relationship. LGBT carers face additional pressures due to a tendency of some professionals and family members to devalue their relationship to the person being cared for. So policies do not explicitly protect LGBT plus rights can result in healthcare professionals or social services being untrained or unprepared to meet LGBT plus needs. Also, legal uncertainty may discourage LGBT plus individuals and carers from accessing necessary health and social care. Health and well-being risks, minority stress and stress associated with stigma, discrimination, and social isolation can negatively impact mental health, increasing the risk of anxiety, depression, or burnout. Fear of discrimination or past negative experience may discourage seeking LGBT people and their carers medical care. Concerns about confidentiality. Fear of outing or discrimination may lead LGBT plus carers to conceal their relationships or caregiving roles, limiting their willingness to seek help. And finally, intersectional challenges, additional factors such as race, ethnicity, disability, or socioeconomic status can compound difficulties faced by LGBT carers, creating complex barriers to support. If we now go to slide 6 and 7, please, the recommendations how to better support LGBT carers. Thank you very much. So to support LGBTQ plus carers, we need to remember about some basics. Firstly, is understanding the unique barriers that LGBTQ plus carers face, using inclusive language, not making assumption, increase visibility around the support you can offer to the LGBT community, monitoring and asking the right questions, signpost people to specific support, to name a few. And most importantly, provide information and advice. So understanding different terminology used to describe LGBTQ plus identities, using diverse and LGBTQ plus inclusive language and imagery in publication, not making assumption about someone's identity, sexuality, or relationship status. Another one is inclusive policies and practices. So create healthcare, social services, and community support policies that recognize and accommodate the unique needs of LGBT carers, ensure that forms, assessment, and service delivery are inclusive and respectful of diverse family structures. Also, targeted training and awareness for healthcare professional. I couldn't stress enough how important that is. So offering training for healthcare professionals, social workers, and support staff to increase awareness of LGBTQ plus specific issues, reduce stigma, and promote respectful interactions. establish dedicated support networks, create peer support groups and community organizations specifically for LGBT plus carers to share experiences, access resources, and receive emotional support. Then increase access to information and resources to ensure that information about caregiving, legal rights, and available support services is tailored to and easily accessible to LGBT plus carers. Then promote legal and policy protections, so advocate to legal recognition of diverse family arrangement, caregivers' roles to ensure equal rights and protections for LGBT carers. Address discrimination and stigma, so implement awareness campaign to challenge stereotypes and reduce discriminations against LGBT carers with healthcare, social within healthcare, social services, and the wider community. Then ensure confidentiality and respect privacy. So guarantee that services respect the privacy of LGBT plus carers and do not subject them to unnecessary scrutiny or discrimination. Provide financial and respite support. So offer financial assistance, respite care, and flexible support options tailored to the need of LGBT plus carers to reduce burnout and improve quality of life. And finally, involve LGBT plus carers in policy development. So engage LGBT plus carers in the design and evaluation of services to ensure their needs and perspective as adequately represented. And if we go to slide 8, please.
Should be there now.
It's okay if you cannot move the slides. The slides say...
I think we can see them, Oliver. I can see this, the resources and organisation slide.
Okay, so resources and organisation who can provide advice and support. So if you need support and advice, please reach out to local LGBT plus community centers or support groups, as they often have resources or can connect you with relevant services. You may contact your GP or healthcare provider for advice on local support services tailored to LGBT carers. And some of the organization providing advice support are the Camden LGBT plus unpaid carers support, LGBT plus unpaid carers, Devon Carers, Carers UK, Action for Care Surrey, LGBT plus Health and Wellbeing, Carers Trust, Stonewell, LGBT Foundation. LGBT Foundation is in Manchester based but offers nationwide support. Switchboard, local authorities and NHS services, Mind also, and other mental health charities. I think that was my last slide.
Thank you so much, Oliver, for your presentation.
Thank you
really
so much,
insightful.
and I'm sorry for my voice is
oh no,
very dry
your voice,
room where I'm sitting today, so apologies.
Your voice was great. Are you going to stick around, Oliver, if you can? I'm going to move us straight on to Cath Pickles from Restitute, if we can, and then hopefully we might have a little bit of time left at the end for some questions, if that's okay. Are you ready to go, Cath?
Oh yes, I'm ready to go.
Wonderful, thank you.
Thanks very much for inviting me. So what I'm hoping, Rachel, is that we can show the first 3 slides relatively quickly and then turn the slides off, and I'll do a lot of talking, and then if we get enough time I'll come back to the slides, the other next 4 slides, but definitely want to show the last slide, if that's okay. Last
okay.
one.
Thanks, Cath.
So this is just my contact details. I understand this is being recorded, so if anybody needs it. The next slide, please, Rachel. Now, this is my telephone number. I would be very grateful if anyone in this room would just make a brief note of it, just in case at the end of this session you feel that you need to have a debrief with me. I wouldn't try to use it to get in touch with me beyond this afternoon, but if you send me a text and anybody needs any kind of debrief or a chat about what they've heard today, please do get in contact with me. The number's going to come up at the end as well. Are we able to move on to the next slide? This slide is really important because for my caring responsibilities, it's very important that people understand this isn't just my story. And I'll talk a little bit about the challenges that this brings for carers working in my field in a moment. But I just want you to know that although this is dated 2023, that was the last time I could pin her down for long enough to get a piece of paper written. But I have actually spoken to her today. I have consent to speak to her. We have active consent. She moaned like hell at me and went, oh, for God's sake, why did you ask me this every single time? But I'll explain why now. So do you want to lose the slides now, Rachel, and I'll talk? It would be great if as many people could put their cameras on as feel able, simply because then I can see the reaction I'm getting in the room, and it does, believe it or not, make it easier for me to speak and measure what I'm saying. I am going to talk about some really, really rough stuff now. So I want people to be aware of the fact that they might hear things that they weren't expecting to hear from someone like me. And I'm going to talk about sexual abuse, suicide ideation, self-harm, and those kinds of things. So if everybody's prepared, willing, and able to live with that, I'm going to get going. Is that okay? Thank you for the nodding. There's a lady at the top of my screen who is nodding away, and it's so helpful. You've got no idea how helpful it is. Thank you. So my name is Cath Pickles. I'm the founder and the CEO of an organisation called Restitute. And Restitute came about because between the ages of 8 and 11, my daughter was sexually abused. We didn't know very much about it at the time. By the time she was 11, we knew that something terrible had happened. By the time she was 12, we knew it was sexual abuse, but it wasn't until she was 15 that we were actually able to nail it down to who it was, because it took that long for her to disclose. And during that time, we faced shame, blame, stigmatization, isolation, criticism, and absolutely no help whatsoever from any services for us as carers. We were assessed by social services, who recognised that we were a good enough family and that there was very little risk to my daughter beyond the point that she'd made the disclosure. And because we were good enough and the risk was recognised that we were good enough and she wasn't, everybody just disappeared. And we then spent the next 10 years trying to keep our daughter alive. We had endless, it felt like a revolving door at A&E. We were desperately looking for support for her. We were desperately trying to keep her alive. We spent endless nights, up all night, sitting outside her bedroom door, just trying to keep her alive. And it is still an issue today. She's now 27 and she is doing very, very well indeed for her. But she has profound physical difficulties, mental health difficulties. She has struggled with alcohol abuse and with drug abuse. She has put herself in very, very risky situations. But if you look through all your carers' documentation and you look through the information that is given out to carers, you won't see us mentioned. Even when we go into A&E, we're not seeing, yes, when we first pitch up with a child who's self-harmed for the first time, we are recognised, we are seen. Someone might say something, but by the time we're pitching up there 30 times, people are pretty fed up of us. And they say things like, what are you doing to prevent this? How are you managing this at home? What are you doing? And the shame and the blame and the stigmatization just piles on and on and on until it gets to the stage where you don't ask for help anymore. You don't try and explain who you are or what the situation that you're living in, because every time you try, someone says, well, you don't quite fit. Well, you're not this, you're not that. I've had a carer's assessment where someone said to me, but this is awful, but I don't know what to do. I don't know what to suggest. We're invisible within most carers' documents. So my first request to you is, if you work in the system, please can you go back and ask your family Family Carers Partnership Board, where is your terms of reference, including people caring for victims of crime, trauma and abuse? Now, shout out to Suffolk, because they're on there, and that's where we were born and bred. And Norfolk is nearly there, I think, and Essex is getting there. What happened next was that my daughter started to become a little bit more stable. We weren't camping outside her bedroom door every single night. And we looked around and we realised that the rest of us had completely fallen apart. My son had become a young carer and we didn't even know it. Nobody knew he existed in the system. I had to give up work, which went to a drop of, well, my income went from above average salary to being able to claim £67 a week, which is what it was at the time. My husband was continuing to go to work and was facing the comments that you don't want to hear, but you think, well, why wouldn't he say that? Because that's what I'm thinking. Like, God, your daughter's a pain in the arse. Can't you sort her out? And that's really, really upsetting when someone says it, but when you're actually half thinking it in your head, because this is relentless and it's going on and on and on. It's very difficult to know how to respond. So after she started to recover, I set up Restitute, and it started off and it was just me and the dog. And I used to include the dog in because that meant I could say we. That was 5 years ago. I thought we'd support between 6 and 12 families in a year, and that was a bit pessimistic or optimistic, depending on which way you look at it, depending on who you're asking now. We've now supported over 600 families. We are on average supporting 200 families a year. We prioritise what families need, and we provide an independent provision to those carers, because everybody thinks that the ISVA service will support people or the criminal justice system will support people, but we're not recognised as victims of crime. Too often we're seen as being the cause of the problem when we so aren't. We didn't know what had happened. We ended up thinking we were completely alone, and it turns out we're not. We're now working with the Home Office to deliver support, but I need carers organisations. I need statutory services within carers organisations to start recognising us. I need sexual violence services within NHS England to include carers as part of their victims of crime strategy, because the opportunities that we can offer and the support that we can give keeps these families together. You have still people turning up at acute A&E who are self-harming, who are at terrible risks, who are suicidal. But sometimes they don't have their carers with them. They don't have their family with them, because they've made one of two decisions. Either their family is completely exhausted and has basically given up, because otherwise it's got to a case that it's them or us. Or it is that the person who has survived the abuse, who has survived this terrible trauma, has decided that they're too much of a burden on their family, and so they don't involve their families in their situation anymore. And these carers probably still do exist, but if they're not getting the support, if when they turn up to A&E they're seen as being a part of the problem, it's going to make it really, really difficult for them to turn it up again. Simple words: how are you? How are you doing? This must be really hard for you. We'll just say we're fine. I promise you, 9 times out of 10, 99 times out of 100, we will say I'm fine, but we will feel seen. We will feel that you don't blame us. And we really need to have this massive change of attitude towards the people who are still floating about caring for these people. Because if we do that, we keep families together. And if we can keep families together, we reduce the risk of homelessness, of drug and alcohol abuse, of poor mental health, of poor educational outcomes, of prison, of homelessness, and ultimately early deaths. But unless we're given the opportunity and unless we are seen in the system, that's not going to happen. Some of you are probably thinking, I've never even heard of this group of carers before. And please don't feel shocked or guilty about that, because every time I talk on this subject, that's what people say. I had no idea. I had never even thought about it. So I'm asking you today to start thinking about it. I'm assuming, Rachel, that the rest of the slides will go through. Yeah? Could you just move to the one that's got the information about my conference?
Just bear with us 1 second, Cath.
Right.
I think Ollie's on it. Yeah, wonderful.
We are flipping through. This is great, isn't it? Sorry, I didn't help, did I, by saying you can stop sharing slides. These are the slides. Hopefully you'll be able to read and be able to, there we go. Now, I don't know if this QR code worked. It worked on my phone, but if it doesn't, I have pre-prepared, and I'm now pressing the button in the chat. That's all the information about the service that we offer. This is a day's conference. If you're sitting there thinking, I have never even thought about this before, please have a look at our conference. It's a day's conference. It's face to face. But we need people to come, and we need people to come and start being champions for this very, very marginalised group of carers. You won't hear many other people like me stand up and speak. Thanks, Debbie. You won't hear people stand up and say, I am the parent or a carer of someone who has survived sexual abuse, because it is the most stigmatised and taboo subject in the world. But I do it because nobody else does it. And I do it because I think we can make a difference. I made so many mistakes when I was trying to care for my daughter. Yeah, sorry, there's so many messages coming up on the chat. I'm trying to read them all and it's really just confusing.
Don't worry, Cath, we'll come back to the chat.
Okay.
I'm keeping an eye on it.
Thanks. The other thing to say, do you remember when I said about waiving the right to anonymity? One of the hardest things for carers is that it's not our story to tell. I'm really lucky that my daughter has waived her right to anonymity, and she is able to do that because she's over the age of 18. But children and young people cannot waive their right to anonymity, and parents are very wary about sharing their story with anybody. So we have to be careful, and we have to be sensitive, and we have to have a safe, confidential, independent place where carers, just like me, can come and get the support that they need. And if they've got that, we can reduce the costs to the NHS enormously. I know unpaid carers do that already, but this is a whole cohort of carers that aren't getting the support they need and who could even crack some of your really, really sequins clients. I think that's all I want to say, apart from ask me anything.
Thank you so much, Cath. A great presentation, and thanks, Oliver. Some really thought-provoking and insightful information that you've shared there. Hands are flying up. We've got about 8 minutes before we're due to finish for lunch. So I'm going to come to Wendy first. Hi, Wendy.
Hi. Just a very, very quick comment, really, and question. Do you know I'm the head of patient experience for St George's and Epsom and St Helier hospitals, and I'm effectively the champion lead for carers. And I used to share an office with the head of safeguarding, and I'm ashamed to say that it's never occurred to me. It's never come up actually. But what is marvellous in a sense, if you take the meaning of that, is we're a couple of projects before we draft our policy for carers, our brand new group policy for carers. And now that I have been here and have heard your absolutely overwhelming story, we can make sure that this is included, and the safeguarding team and the mental health associate directors are included in considerations about this policy, and we can link it to the other respective processes and everything else. So thank you. Wow, just thank you.
Thank you. And if you need my help, like I said, I've put all the information in. It'd be great to see you at the conference because the lineup is incredible. I realise that NHS budgets are really tight. If there's a barrier, let me know. We can sort it out. Please have a look and contact me about it. I've got someone called Janice up next. Is that for me, Janice, or for Oliver?
It's for you. Yes, thank you for that. I mean, you're very brave in talking about that, but I don't just want to give plaudits at this point, because I think there's some very useful work we can all do as carers, as unpaid carers, and people of influence. And I'm lucky to be working in the same county as Wendy. I'm a Surrey and Borders Partnership Trust, Mental Health Trust, Care and Families Governor. And I've worked with Debbie Hustings, who's also on this call, to get carers into the suicide prevention strategy, because although that's not the main purpose of your talk, it's an outcome of what happens to families that you're talking about, including, you know, your suicide ideation. And perhaps, Debbie, could you put the link in again to the research that we used as evidential source to persuade the Surrey Carer strategy, suicide strategy, to include carers in that. Unfortunately, the national one doesn't include carers. And
can we just come in to say, Debbie, I know about the 40% of parents of children. What I'm also very aware is the research that we've done. I've put the link in the chat. Is that our parents are suicidal as well.
Yes,
because
exactly.
they're traumatized by what has happened to their loved ones, but they're also traumatized by the system. They're re-traumatized by the way that they're treated by society, and they're so hidden. So I can almost guarantee that carers like me haven't been included in that data, because I'm sorry, I've completely forgotten your name and your picture, and now I can't find it. I'm going to find it. As Wendy said, you know, it never even occurred to her, and I get that completely. That's why I set up Restitute. But, you know, so if Wendy doesn't know about us, then how can we have been included in any kind of statistics? The research document that we've put in there captures heartbreakingly the challenges that our parents and carers have found. But I really do want to give some hope. What we're doing here at Restitute is evidenced to work. It's working for the carers, and it's working for the people that we're caring for. But it doesn't always involve therapy. Parents need a safe space where they can go to work out who the hell is going to pay the mortgage now. There's nobody left in the house who can change the light bulbs. And when you start empowering these parents, they do return to the place that they were, which is why we're called Restitute. Somebody else had their hand up.
Thank you so much, Cath. We have got a question in the chat for Oliver, if that's okay, if we just quickly bring that in. Oliver, somebody in the chat's asked if there's any data on the number of people who are caring for people going through gender reassignment. Debbie's concerned that the current waiting times of 6 years might indicate unmet needs. Do you have anything you could comment on that, or any links you could share? Oh, we've lost you, Oliver. Okay, hopefully Oliver will be able to come back to us on that. Any other questions? We've got 3 minutes.
And Rachel, can I just come back on that question very, very quickly?
Yeah,
it's Debbie.
Hi, Debbie.
I'm very interested in this cohort of carers. I've actually met a parent carer who had been waiting 9 years so far. That's because her adult son, the wait time for adults is longer than children, and she felt completely outside of any service provision. So I was curious in terms of protected characteristics, why that data, if it's not collected, isn't collected, because we should be. So if we could just add that to Oliver's question when he's able to, and I'll let Patricia's waiting.
Question list. Yes, thanks. But yes, Debbie, we'll definitely add that question to this. Thank you so much. Patricia.
Hi, I just wanted to say to Cathy, thank you so much for sharing that powerful message to us. And I just wanted to say, I think you as a mother, I think we did very well, because I come from the global majority, and sometimes, when these things happen to young people, they don't even come up to actually talk about it until death. Maybe some people don't even say anything. And the fact that she actually came and say that and you supported her, it's very important, because I think as for our culture, my culture background, you'll be blamed for it instead of being supported. So sometimes people do not share anything with the elderly. And surprisingly enough, the people that actually abuse them are those that are actually close to them. So as I'm now in this country, I always teach my children that, I always make sure that they know who is a stranger, because the people that you call aunties all the times, and they're not actually your auntie, are the same people that also abuse you. So hands up to you both for listening and supporting your daughter, and for her to be able to have that safe space to trust you and support her, which some of the cultures can do that. And to all professionals that are there, I think it's also good to acknowledge that some background or minorities, people cannot actually come up and talk about it. So it would be nice to have those questions where you can prompt, and ensuring that they have safe space to actually talk about it in a safe place, if it makes sense. Thank you.
Thank you so much, Patricia. I'm so sorry, I've done an awful job of chairing. Apparently we should have been back in the main room a few minutes ago.
Can
So
I
you
can I
can blame
just
me for
respond
that.
to that? Can I just respond to that? It'll take
Yeah.
me 30 seconds.
Oh, of
So
course, yes, Cath.
thank you. So just to say, Patricia, one of the things that children say a lot is my mum okay? Is my mum okay with me? And we can encourage and increase the rate of disclosure if we start sending the message to children that if you say, we will look after your mum or your dad or your brother or whoever it is, because children know the bomb that is about to go off. They can envisage the family chaos that is going to happen. What they can't envisage is what it's going to be like 10 years' time, when they are really, really struggling mentally and physically, and with all the family breakdowns. So we have to change the narrative. 7 out of 8 people do not disclose. So that's 7 out of 8 people who are being abused, who have never disclosed what's happened to them. We've got to change the way that we encourage children to disclose, just by saying you must say something. They're not stupid. They know, they can see, even really little people know that if they say anything, Granny's going to get really upset. They know this. They are not daft. We have to make it so that children understand that their families will be safe if we do it, if they do it. Sorry, was that quick enough?
No, thank you so much, Cath, and really again, thank you to you and Ollie for your presentations. Really powerful, and so much bravery in sharing, and we're very grateful. See you back in the room, back in the big room. Okay, thanks guys, take care.